Hey everyone, I'm Mariana Parks, physical therapist, and today I interview Dr. Jill Cook, and she's going to talk about Tendinopathy Differential Diagnosis. Dr. Cook is a physiotherapist who, after a clinical career of 20 years, became primarily a musculoskeletal researcher. After completing her PhD in 2000, she has investigated tendon pathology, treatment options, and risk factors for tendon injury. In our discussion today, you are going to learn tendinopathy, mechanisms of injury, about the different stages of tendinopathy pathology development, what you should look for in the clinical assessment, differential diagnosis, and treatment options. So if you feel this information is valuable, please consider subscribing to our channel, clicking on the bell so you don't miss anything, give us a thumbs up, and share with other clinicians you feel might benefit from this conversation. I hope you enjoy the show. PT Pro Talk podcast is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today.
Balance is the essence of movement, and movement is the essence of life. This week's episode is brought to you by Fitter First, creator of the ProFitter, the original 3D cross trainer that started the functional fitness revolution in 1985. Its timeless design is loved by PTs and trainers for balance and strength of the upper, core, and lower body. Find it and other great Fitter First products like wobble, rocker, and soft boards, as well as slant boards and the new FitFoot at fitter1.com. That's FITTER numeral 1.com.
Hi Jill, welcome to PT Pro Talk. How are you today?
I'm excellent, thank you. And yourself?
Awesome, doing good. Hopefully pressing to this tornado watch. Hope everything's gonna be fine. So let's just get started by talking a little bit about yourself and your background for the ones that don't know you.
Yeah, I am a physio by training and spent many years working first just in hospitals and generally, and then to sports medicine, and travelled with teams for quite a few years, probably 15, 20 years, and then decided to do my PhD, finished that, and then have had a research career since then, and still will try and mix up the research and clinical work a bit.
Awesome. So half and half almost?
No.
Half a clinician?
Oh, a little bit less of everything now because I'm officially doing much less. I'm officially retired, but I'm still active.
Okay. And during your career, you had a big part of it that you work as a clinician, and then the other almost half maybe as a researcher?
Yes. And that connection, I think, is really, really important, that you can't, as a clinician, lose sight of research, and as a researcher, lose sight of clinical practice.
Absolutely. Yeah. Well, so let's start talking about our topic, tendinopathy. Everybody knows which topic we're going to talk about. So let's just start talking a little bit about how does that injury occur, how a tendinopathy starts.
So tendinopathy, by definition, is pain and dysfunction in a tendon. And people conflate or mix up tendon pathology that you see on imaging and actually the presence of pain and dysfunction. So if we're talking about tendinopathy, it starts when somebody has an underlying pathology, and what happens is they overload the tendon in some fashion. So usually they do more activity or one specific activity, or sometimes they have had some time off and then return to an activity. And that creates pain in the tendon. That then creates more dysfunction, and then you get caught in this cycle of more pain, less activity, poorer function, and on you go until somebody intervenes and changes something.
So on these different stages of the tendinopathy, could you just talk a little bit about the stages and what we can do as PTs in each stage?
Yeah, so that's a good example of thinking that pathology is the same as tendinopathy. So pathology has stages. So we talk about the reactive stage, which is an acute onset of change in the tendon. It happens in young people, happens with an acute overload or a direct blow. It's relatively rare. We don't see that much of it unless you're working with young athletes all the time. A disc repair is where the tendon starts to lose structure, and we really can't tell that very well clinically. It's sort of a transition phase, and then the tendon becomes degenerative, which is where the structure is completely irredeemable, as in not all of the tendon, but part of the tendon has a pathology in it that can't really be changed. And you may have that and have no symptoms. And what happens when you overload a tendon that has degenerative change in it is you get a reaction in the normal part of the tendon, which is called reactive on degenerative change. So the times that we can act is in a true reactive tendon, relatively rare, that needs to be unloaded and placed in a situation where the tendon is not rested but isn't exposed to too much load. A reactive on degenerative tendon is the other place that we can intervene. It tends to be in, middle-aged to older people, but can occur in our 20s, of course. And in that case, it needs just again to be underloaded or take some of the provocative load off it, and then add exercise and load that actually restores the function in the tendon and the capacity in the tendon.
I think that many people probably get confused between these two stages because a lot of people are afraid of loading tendons, especially like in more acute stages, right? So when you say unloaded in a reactive state, that is like a relative rest. So like, what do you mean? What would you give them as a load, but not loading too much?
Yeah, so tendons are affected by 3 loads, and usually the one that gives us the most trouble is the energy storage and release loads. That is where the tendon acts like a spring. So that's sort of athletic activity, jumping, change of direction, those sorts of things. And they're the loads that are the first to be removed in somebody that presents with pain. And what you'll find is they'll have a history of adding those or doing too much of that sort of loading. The 2 other types of load that we see that we have to consider is compression in and around the insertion of the tendon. If somebody's done a movement that's caused compression on the tendon, you have to remove that load as well. And the 3rd load is a friction load that causes a peritendon problem. Now that's less common because most tendons don't have a substantial peritendon, but certainly in the Achilles, foot and ankle tendons, wrist and hand tendons, that's a factor. So what you have to do as a physiotherapist, physical therapist, is identify which loads cause the problem and remove that. And it might be energy storage and release. It might be compression. It might be both. And then come down to a load that's going to be non-provocative and or helpful. So we know our heavy isometrics are helpful in terms of pain and cortical inhibition. So they're always a good load to go with, and it keeps the muscle sort of active and as strong as possible. But also slow loading is not usually provocative for tendons. So we can usually do either isometrics or slow heavy loading out of compression if it's an aggravated tendon.
And that will be okay also in the reactive stage.
Yeah, true reactive tendons, very hard to pick clinically and not seen that often, are very irritable. You can't, they tend to be more irritable than the reactive on degenerative tendons. You have to be a little bit more sensitive to that. So you might find that you need to just start with your isometrics and wait and see. So they can take a few weeks to settle down if it's a truly reactive tendon. But I want to emphasize again, they're not that common. We see them in younger people. Direct blow is probably the most common way you will see it in an adult. And I don't know if anybody's ever experienced it, but they can hurt for quite a few weeks. So you have to be a bit more considered about your load in a true reactive tendon.
And how do you differentiate them? Is more through like the patient's age and the mechanism of injury? If they had something, yeah.
Yes,
okay.
That's pretty much it. If they're younger and they've had a silly overload, the classic being young, talented athletes that go into a national camp, so where they train every day 2 or 3 times and they're used to training 2 or 3 times a week. So a sudden change in load will be a red flag for it being reactive in a younger person.
And in that case, you have to give them a little more time and less load comparing to the generative reactive. Yeah.
Yes, absolutely. They can often be several weeks to settle down. And again, as I say, the corollary is the direct blow. And as I say, they tend to take sort of weeks as well to settle down. So yeah, both of them are a little bit slower than the reactive on degenerative. The reactive on degenerative will often settle in 7 to 10 days. So if you take those provocative loads off, it'll tend to calm down very quickly, and you can then get some positive loads on it, relatively quickly compared to a true reactive tendon. So I guess from a clinical perspective, if you are giving people loads and you know that it's a tendinopathy and it's not responding very well, then you could be thinking it might be reactive if all the other parts of the puzzle fit.
Yes. And then if they are in a more chronic condition, would they still be able to have this reactive on the degenerative, or it's more like in acute conditions that you see that?
Reactive on degenerative tendon tends to be a chronic in inverted commas. That's a hard term to define, but often people who have a degenerative tendon will have repeated bouts of tendinopathy. So they'll be fine for 6 months and then they'll do something silly. They'll get tendon pain. It'll settle. Often it settles without intervention. And these are the people that say, oh yeah, my Achilles is a bit stiff again. I'll just be careful about how I run today. And then it'll settle down and then they'll go a couple of months and then it'll happen again. So if that's what's chronic, that's a classic reactive on degenerative sort of presentation. They sort of go in and out of the reactive phase when they do too much. So one of the key things in your history is, have you had it before? And they'll say, oh yeah, it happens all the time. Or sometimes, oh yeah, I've had it on the other side. It happened, 10 years ago. And then you pretty much know that it's degenerative tendon and this is just an acute sort of reactive on degenerative response.
And in that case, would you give them some time to rest, or you would start loading right away?
Loading right away. So you can do in a reactive on degenerative tendon, start your isometrics pretty much immediately. You can usually start some slow, heavy loading within a couple of days without too many problems. And you can certainly work above and below the tendinopathy, so the muscle tendon unit. So remembering that pain causes you to unload, unloading causes dysfunction. Dysfunction will occur throughout the whole leg. So you can actually really work hard on the bits that are not affected by the pain, be considered about your load in the painful tendon, but also work very hard on the rest of it.
It's really good to hear that, because I feel like a lot of people are very scared of putting too much load or load right away, especially patients that come from the doctor that ask for rest. Don't put weight, don't overload. So I think it's good to just hear that so we can try to be better with our patients.
Yes, because what happens is, if we know there's a relationship between pain, unloading and dysfunction, and you get weaker and weaker, if you continue to rest somebody with a tendinopathy, they just get worse and worse and worse. They'll get better while they're resting, but what will happen is you'll put them back into some sort of loading environment and they'll be terrible because you've rested them for an extra few weeks, and so you become part of the problem by not actually intervening in as early as you can. And you can do things like, if you have an Achilles problem on one side, you can work the other calf Achilles hard and you'll get a 20% increase in strength on the affected side. So even just working the other side can be very beneficial. So we can do a lot of things instead of just doing nothing, being passive in our interventions, using modalities that are not going to do anything. We can do a lot and we will benefit the patient.
Yes, absolutely. And on the clinical assessment, what are the signs, what you're looking for to identify these tendinopathies?
Okay. So this is really important, and we're driven very much by both the medical model and the pathoanatomical model. That is, if you have a pathology, then you have a problem. And if you fix the pathology, and you'll get better. And if you can see the pathology on imaging, you have a problem. And none of those things are true. So it doesn't really matter what your imaging looks like. You can still get complete recovery of your symptoms and be completely functional. So we do not look at any of those markers. We look at two things from a diagnostic perspective. We're looking for localized pain that stays localized with load, and we're looking for a load-dependent increase in pain. So as we increase the load on the tendon, the pain will get worse. There are other signs. So for the Achilles, for example, morning stiffness is a classic sign. For patellar tendon, hamstring tendon, sit pain is a classic sign. But the two key things would be localized pain that doesn't change with its position with load, and second, that load-dependent increase in pain.
Okay. You just mentioned the hamstring by sitting, increasing the pain?
Mm-hmm. Yep, hamstring tendinopathy occurs at the ischial tuberosity, and sitting on a hard chair particularly, or a low chair, is very provocative for those. So they will report localized pain at the ischial tuberosity. We put them through a series of load tests as we increase the load on that tendon, and their pain goes up. But they will classically report not liking sitting.
Very interesting. It's just irritating the location.
You're just compressing the area. And we know that all bone tendon junction problems, so that's everything aside from the Achilles, mid-Achilles. So every tendon we talk about in the lower limb is actually an 𝗏𝗔𝗄𝗏, a bone tendon junction problem, and compression is always part of that. And so that anything that compresses every tendon will create problems for it.
I heard you mentioning before in another podcast about sitting and knee pain with sitting. Would that be like a similar issue in the sense of?
Yes, it's interesting. So we know that sit pain causes anterior knee pain. And so it's not diagnostic in that pain with sitting can be patellofemoral in nature, but it can be patellar tendon as well. Patellar tendon pain tends to be in the car for some reason. I have no idea why it's like this, but they report pain in the car, and they report sometimes it's so severe that they have to stop and get out of the car and straighten their leg. So that to me is a little bit of a sign that it might be tendon-related pain, whereas somebody with patellofemoral pain can often sort of wriggle around and straighten their leg a bit and be painful, but not necessarily needing to get out. But people with patellar tendon pain, if they have quite severe pain, will report that they can't sit in the car for any length of time at all. So that's quite interesting.
It's different than the idea of having load, so it gets confusing when you think about the classic symptoms.
It's just another sign that makes you think it might be tendon. It's not diagnostic, but you just put it in your brain and think, yeah, maybe that is tendon. So apologies, keep going with what you were saying.
No, because I was going to say that I had a patient with the same symptom of having to leave the car, but because of that pain on the hamstring, on the insertion, so she couldn't, she had to lift her hip on the side. She couldn't tolerate sitting. And that would not come to my mind. That would be a tendinopathy at first. So I think that's very different. So I'm glad you're talking about this.
Yes, it's very classic that hamstring tendons don't like sitting in the car because the seat's quite low and you're often sitting quite a long way forward, your legs out straight, so your hamstrings on a little bit of stretch. They really, really don't like sitting in the car.
Very interesting. And you mentioned about the Achilles tendinopathy, about being stiff in the morning, right? That's another symptom that helps you to identify. Do you know why that happens?
No, there's not been any research on this. It's a research project that's ready to go. You could easily do a project on this. It's probably something to do with a change in the water content of the tendon so that it fills a little bit with water. So instead of it's a very poor analogy, but instead of the fascicles and the collagen being quite tight, they sort of get separated a little bit by extra water that can come in overnight because you're in plantar flexion. And then you get up and you sort of almost have to squeegee the water out. And once you've done that, it's fine. So people will take a couple of minutes, sometimes up to 20 or 30 minutes for the tendon to be really back to its normal self in inverted commas. But if you don't have morning stiffness, you have to be thinking about a different diagnosis if you're talking Achilles pain.
So that's a very classical one that you're looking for if
Absolutely.
It's like a tendinopathy. Okay,
Mm-hmm.
Very good. And just another question about pain that you mentioned. Sometimes you have the pathology, but you don't have the pain. And in those cases, why some people that have the pathology don't have the pain and some people have the pain? What would be the difference?
So we don't actually know the source of pain in tendons, but it's not different from osteoarthritis or back pain or anything. You know, the source of pain in many of our musculoskeletal conditions is unknown. But clearly it's not the pathology, because otherwise everybody with pathology would have pain, and they don't. So it's something to do with perhaps that reactive change in the normal part of the tendon, so our classic reactive on degenerative pathology. The degenerative area is stable and non-painful, but if you overload it and you create a response in the normal part of the tendon, that might be the source of the pain. So it might be the cells in that normal part of the tendon. When you overload it, you create some sort of output from the cell that stimulates the nociceptors, and that creates your pain. But the pathology itself isn't painful, because if it was, everyone would have pain with pathology.
Yeah. Okay, it makes sense. And anything else on the clinical assessment that you're looking for? You said pain localized, that doesn't change, right? And getting worse with load, progressively getting worse. Anything else that you're looking for on your assessment?
Yeah, there's a lot of little things that sort of cluster around that. You want to be sure that you don't have a systemic disease. You want to be sure, probably the most important thing is finding a link between overload and onset of pain. I'm always unhappy if someone comes in and says, my tendon is sore, and you will say, what have you changed? What have you done that's different? And they'll say nothing. No, I've changed nothing. I've done nothing different. Then I'm worried about my diagnosis immediately, because everybody with a tendinopathy will have a change in load, and it can be something quite small. So if you are a distance runner, it can be a change in shoes that create the problem, or a change in running route that creates a problem. So it can be very subtle in some people. In other people, it can be quite obvious. You know, they've decided that they want to start to do some running. They've not run for a period of time, and they've been out trying to jog. That's a very obvious change in load, and both of those things can bring on a tendinopathy. So I need to find a difference in load. And if I can't, I'm immediately suspicious of my diagnosis, and I'm extra careful with my assessment and both my subjective and my objective assessment.
Okay. It just brings me one patient to my mind, that same one that I mentioned about the hamstring. Because on the history, the pain started when the patient was sitting, working on the guarding in a hard stool. Would that be considering a load that could provoke that tendinopathy, or?
Likely not. Likely that's the first sign that she's had something. I would go back further in her history and say, what have you been doing differently before you noticed this pain when you were sitting? So have you been bending over a lot more, doing some more gardening? Have you been running more hills? Have you been doing anything different so that would provoke a change in the tendon, so a tendinopathy that you would then notice by sitting. So the actual sitting won't create problems. There'll be something in her loading history prior to that that will tell you what the load is that's created the problem.
Okay. That's more like the symptom, the
Yes.
after. Still talking about assessment, I was really curious to ask you about the differential diagnosis that we know it can be very tricky and confusing, all the signs and symptoms like we're talking. Would you walk us through like some of the main differential diagnoses in the most common tendinopathies?
Yes.
Awesome.
So it's a long list, can I say? So the Achilles is probably one of the hardest ones because we have 3 or 4 Achilles-based diagnoses. So we have a classic mid-Achilles problem. We have an insertional Achilles tendinopathy. We have a plantaris-associated tendinopathy. And we have a peritendon-associated tendinopathy. So we actually have 4 tendon-based diagnoses, and you have to be clear about which one of those you actually have, because the insertion is more about a compressive load. The classic mid-Achilles is more about energy storage and release. The peritendon is more about a friction load, and the plantaris can be both compression and or friction. So can you see how important working out the load is to actually making your diagnosis? So that's just in the Achilles itself. Then you have a range of structures around the Achilles that can mimic Achilles pain. So we can have posterior ankle joint symptoms. We can have sural nerve symptoms. We can have superficial bursa that can create symptoms. We can have issues in and around our posterior retinaculum that can create issues. We can have a classic neurally mediated signs and symptoms. We can have our medial tendons, so our FHL and FDL, on the medial side, tib post. We can have perineal tendons on the outside. And people with their diagnosis, if you come back to localized pain that stays local with load, will often help you sort that out, because if they don't point to their Achilles, they point more to the inside or to the outside, you can sort of start to think maybe this isn't a classic Achilles. So there's a lot of things going on in and around the Achilles. The problem we have is you can have Achilles tendon that might be plantaris associated and might have a peritendon, plus you might have some neural signs. So you can have 2 or 3 sources of pain, and you have to deal with each of them. You can't just hit them with a tendinopathy program, because you might help the tendinopathy, but you might provoke some of the other conditions. So Achilles is quite a hard one. In the patella, in and around the patella tendon, by far the biggest differential diagnosis is patellofemoral joint pain. It's far, far more common than patella tendon pain. Patella tendon pain is relatively rare. We see it in young jumping men, very occasionally in elite jumping women, and almost never in anyone else. So we see far too much overdiagnosis of patella tendon pain and not enough diagnosis of patellofemoral pain. So even if you have signs and symptoms over your patella tendon, and it can be quite localized, it can still be patellofemoral in nature. So patella tendon is way overdiagnosed, and you have to be very careful with who you label with that condition. The good thing about patella tendon is it's either tendon or it's patellofemoral joint. It's not both. So it's not like where you can have a lot of different things in play. It will be one or the other.
And how do you differentiate them? Just through the history and the age and the activity level?
Yes. Your examination will give it to you. They have to be doing a lot of jumping and change of direction for it to be tendon. But having said that, it can still be patellofemoral joint. The decline squat can really help us. It's provocative for all anterior knee pain, but you see a difference in the range that they can achieve and the amount of pain that they get. So if somebody with a tendon hops on a decline squat, they can only go to about 20 or 30 degrees and their pain's immediately very high, so 8 out of 10. Whereas someone with patellofemoral pain can go deeper into range and has, 4 or 5 out of 10 pain. So that's a good differentiation. Second differentiation is how they hop. So somebody with a patellar tendon will hop with a very stiff knee, does not want to bend that knee at all. Somebody with patellofemoral pain will hop with a softer hop. They can get into more range. They have less pain. So those two things are really helpful to discriminate. And then the third thing, if you have the capacity, heavy isometric loads, as 𝗏𝗵𝗲𝗏 did in her study, will really help somebody with tendon pain and really hurt somebody with patellofemoral pain. So if you give them a bout of isometric exercise, the person with patellofemoral pain won't get through the first repetition. It'll hurt too much. Whereas somebody with tendon pain will get a little bit of pain in the first rep and then get better and better as you do more reps. So there's quite a few ways you can actually discriminate between the two. But really age, gender, loading is the classic. If they're not young jumping men, then they are unlikely to have patellar tendon pain.
Very interesting. That's very helpful.
So hamstring tendon, classically two sort of groups. Middle-aged runners is the classic group, often women more than men. Particularly people who have the poor running style, so they lean forward and overstride. People who run hills are both vulnerable. And then the other end of the spectrum is the younger, deep flexion people, so the hockey players, field hockey, something like that, where you're doing a lot of work with your legs straight and your body down near the ground. So for us here, Australian football is another one where we will see it a bit. So they're the two groups you tend to see it in. It will have classic signs. It's an energy storage and release problem as well as a compression problem. So they hate being in hip flexion because that compresses the tendon. But if you do energy storage and release in hip flexion, then you'll really provoke them. But there are a lot of differential diagnoses around there. Again, you want that localized pain, but the sciatic nerve sits right next to the hamstring. And so you can actually get not a sciatic nerve irritation, but a perineural irritation where the pain stays localized, but your examination shows that there's a lot of neural sort of background to your examination. So they are helped by neural interventions and provoked by neural sort of irritating the neural structures. So that's by far the most common diagnosis. You can get adductor magnus tendinopathy around there. You could get, all the buttock type things that can sometimes give you that sort of sense of pain in and around the lower part of your buttock where you get your hamstring. So that's quite a hard diagnosis. In terms of differential, if it's not hamstring, sometimes it can be quite hard to sort out exactly what's going on. So that's another tendon where it can be a bit of hamstring and a bit of something else. So you actually have to be able to sort that out. And then, of course, the last one that I tend to talk about is glute-med. That's, in inverted commas, relatively simple. That tends to be postmenopausal women, very less common in men. Very uncommon in young people and particularly in young men. So it is very much a condition of women. It is usually a relatively inactive, sedentary, overweight woman who's done more work suddenly. So classically it will be, someone who's retired in their 60s, booked a trip to go to Europe or South America or somewhere, done a lot of walking that they're not used to, and their hip flares up. So they have classic signs as well. So night pain is the classic with these. They hate lying on their side because that causes compression. They hate lying on the other side because that causes compression for where the leg is. They don't like stairs. They don't like slopes. They don't like going down or up, either of those things. Their pain is localized over the greater trochanter but can extend down the leg because of the bursa that are involved in and around that area. The caveat on these older women is they always will have some hip OA, and you have to decide whether, in fact, it's the hip joint or the glute med. Angie Fearon did a great study where she found that one question was really helpful is, do you have trouble putting on your shoes and socks? And if the answer is yes, it's more likely to be hip joint. If the answer is no, it's possibly glute med. So that's a really good question to ask if you're trying to discriminate between those two conditions. And then, of course, there's good data to show a lot of these women have degenerative spines, lumbar spines, and so you can get a referred pain. So that's a monster of a differential diagnosis problem. But the good thing is, and again, they can have multiple things, but they respond very well to very simple isometric exercises. So you can often help them a lot and then try and sort out the rest of the condition. So you can see that it is a bit of a minefield, and I'm talking for far too long, I know that. But many of the people that we see in the clinic have come with a tendon diagnosis and they don't have tendon pain. And if you get it wrong, you're giving them the wrong intervention and they're not getting better. You're frustrated, they're frustrated. Getting it right is so important.
Yes. Okay. And you just mentioned about the isometrics that they would respond well. So that could be using all of these cases as a differentiator in all these different pathologies, you feel like?
Yes, absolutely. A true tendon will respond to isometrics. The issue is making sure you actually have a tendon diagnosis and that you don't have a condition contributing to your pain that might be aggravated by your isometrics. So I think separating people into true tendon pains and tendon pain with something else and not tendon pain is really important. And the isometrics will help the true tendon pain.
And how would you apply those isometrics? Would be, like you mentioned, like a little longer, or like a higher intensity of the isometric for like, I heard you saying that before, about 5 times, 2 minutes rest. How would you apply those isometrics? Because sometimes it's very relative. Some people do some isometrics and, don't have the results. So how would you apply those?
Okay. So the two parts of it that seem to be important, and we're not absolutely sure about the amount of load and the time that you need. So some of the research says longer holds. Some of the research says you can get by with shorter holds. But we tend to go with longer holds. But I think outside of how long you hold it for, it's got to be a fairly substantial load for the tendon. And the best way clinically to do that is the load that you can hold well for the time you need the isometric held. So we usually use our, 45 seconds. We want somebody to get to the end of 45 seconds still with very good ability to hold the position or the load, but only just. So if they start to get some perturbations and some fasciculations and shaking because their muscles really tired, the load is too heavy. If they get to the end of the time and they're still talking about their chicken dinner, the load is too light. So we want them to be able to hold it well for the length of time we do our isometrics. And I think that is very often where we go wrong. So I think with isometrics, we go wrong in two places. One, we're trying to do isometrics on somebody who doesn't have tendon pain. That's the first thing. And the second thing, when we do it, we don't load them enough. So we do, some TheraBand or something like that, resistance, which is just not going to be enough. You probably need, in most people, to have body weight loads at least. But, how you manipulate that is your clinical decision.
Okay. And what would you expect? A temporary relief? Like what would be like, okay, that's tandem. So they get a little better and then it comes back. So what do you expect?
So we would expect that immediately after the isometrics, there was at least a drop by half of their pain. So we would assess their hop pain or their decline squat pain before we did the isometrics and rate it out of 10. So it's a 6 out of 10 pain. And then do the isometrics. We would want it to be 3 or less. So at least drop by half. If it's 6 before and 5 after, 2 things. You either isometrics aren't heavy enough or long enough, or it's not tendon pain, or your primary pain is not tendon related. And so you'd go back looking for something else being the source of your pain. If you don't get a substantial change in pain immediately, something needs to be reviewed. And if you do get a substantial change in pain, it usually persists for several hours. So these people will get a benefit, 4, 6, sometimes even longer hours from their isometrics, which is wonderful if you do have somebody with tendon pain that responds to isometrics, that they can use it regularly to relieve their pain.
Very good. And going back to the gluteal tendinopathy, when you mentioned the sciatica, that patient had some pain radiating to the leg. That got me even more confused because I was like, well, maybe it's coming from the back, maybe something else. Oh. But that could be because of what you just mentioned. So that's very interesting too.
Yes. There could be some irritation of the sciatic nerve near the hamstring tendon. They could have hamstring tendinopathy and something else. So if their provocative load has been too much hip flexion and energy storage in the hamstring tendon, that's going to really be a big load for the sciatic nerve in the back as well. And so you actually have to separate out those 2 things. It would be really good to do an isometric for that person and see how much it changes their pain. Then you can say, okay, I have this much tendon pain and now I've got to work on the rest of the problem.
Yes, very good. And just one more question about the differential diagnosis, the Achilles tendon that you mentioned, all those 4 tendon-based diagnoses. So very quickly, how would you differentiate between the classical, the insertional, and all of those?
Right. Okay. So location of pain is really important. Your insertional Achilles will be at the top of the calcaneus, usually middle to lateral, whereas your mid Achilles will be right in the middle of the tendon. Okay, so they're quite easy to differentiate, those 2. Your plantaris-associated one tends to be a little bit higher than your mid Achilles and often on the inside. So it will be just perhaps another centimetre or 2 further up and towards the inside. It can be across the tendon, but classically it's towards the inside. Your peritendon will be a little bit more distributed, so it won't be in one particular spot. It will tend to be a little bit more diffuse. But the key thing is what load created the pain in the first place. Okay, so your peritendon will be caused by too much movement and not much load. So it will be using ankle dorsiflexion or plantar flexion that creates the friction load. So going back to that history that we talked about, what was the load that created the problem? It will be the friction loads that create the problem. And so they will talk about, swimming a lot. So they're doing this with their foot or riding a bike where there's not much tendon load, but a lot of movement. So that will be your peritendon. Your insertion will be more about dorsiflexion. So doing a lot of pushing off where you're compressing the tendon. Remembering insertional tendon is often a manifestation of systemic disease, so autoimmune type of conditions. So your arthropathies, such as the psoriatic arthropathies, gut-related arthropathies. So you have to always be a bit careful around those, but it'll be about too much dorsiflexion, energy storage and release in dorsiflexion. So that'll be the provocative load. Excuse me, the plantaris-associated one's a bit more difficult because that's a sort of anatomical thing. It can be about too much movement. It can be about too much load. You have to have pretty good diagnostic skills to pick that one up. So that can be a little bit more difficult to pick up.
And then how would that change our approach in the treatment? Would you do like different angles or different loads to each of these conditions?
Absolutely. Absolutely. So for your peritendon, you stop movement. So you give them a big heel raise, and I'm talking, 2, 3, 4 centimeters heel raise, so that you're not going through a big range of motion. And they don't like loading particularly. So these are the ones where you might use less loading in the early stages. So just take away their movements. We use a 𝗏𝗄𝗏𝗡𝗏 cream on them overnight. That tends to be very helpful. But the key thing for them is to stop the movement. So that's important. For your insertion one, it's about stopping the compression. So again, a heel raise can be really important. Again, 2, 3, 4 centimeters, sometimes a bit more, where you're not allowing that tendon into too much dorsiflexion because that's the irritation, and then adding isometric load or loading into plantar flexion, type of ranges. So from not necessarily full plantar flexion, but mid to upper range. So you get some load through the tendon without the compression. So that would be really important. For your true mid Achilles, it's about isometric loads for starters, and then your strength through your muscle tendon unit, so your heavy, slow resistance type of load.
Okay, very good. That was a lot of good information there. So usually on the treatment, you usually start with isometrics and slow, have resistance for the first period of treatment time. And then if the patient need it, you're going to do a more plyometric, like a faster rehab if needed. But usually that's how you go about treatment?
Yes.
Okay.
You can't progress people to the energy storage and release part of the rehab unless they have good muscle tendon capacity. So if your muscle strength and your tendon stiffness are so important. So you have to set a good base with your slow, heavy resistance training before you go on to the energy storage and release loads if you need to. So strength underpins everything. So muscle strength, tendon stiffness underpins everything that we do with tendons. You don't go very far unless you have a strong muscle tendon unit. And then, of course, you need a strong kinetic chain as well. So, our patella tendon is highly affected by how effective our calf muscle is. So if our calf muscle isn't absorbing energy and landing, then it's our patella tendon that will take the load. So actually putting it back into the kinetic chain is really important as well.
And any difference between doing open chain versus closed chain, eccentric, anything about those?
Yes, lots of things about those. So you have to isolate out the muscle tendon unit. So very often, one of the loading strategies we see that people have been given that's not very effective is multi-joint double leg exercises. So what happens if you do those, so like a squat, is that everything will work except the affected muscle tendon unit because the brain's got, very used to actually inhibiting movement in that unit. So we absolutely will go with leg extensions and for the patella tendon. We will do calf raises seated and standing for the calf. We will do hamstring curls or bridges or lifts for the hamstring tendon, and we'll do our, hip hitches and things for our glute tendons. So we really isolate it out and get the muscle tendon unit strong. Then we will put it back in the kinetic chain. So the patella tendon, lots of leg extension, then leg press because that actually makes the tendon work in the kinetic chain, and then squats, single leg squats, Bulgarians, split squats, those sorts of things to go up the chain. And then, of course, the jumping change of direction. But absolutely. And usually both concentric and eccentric, so isotonic exercise. Rarely we will do just eccentric. In fact, probably never, unless somebody's really struggling with their load, and in which case we would prefer to drop the load and do a concentric eccentric movement, so an isotonic movement, usually fairly slow, so that you get a lot of time under tension. And then, of course, the isometrics are separate and are done not necessarily for strengthening, or they do give you a strength benefit as well, but they're usually done for pain and cortical inhibition. But it's a slow, heavy resistance through range that's really important.
And what people usually talk about is eccentric in those cases. I think eccentric is very popular.
Yes. So that sort of comes from some original research by 𝐏𝐸𝗡 back in the 90s. And he reported massive benefits for people with Achilles tendon. And then before that, Kirwan and Stanish actually advocated for eccentric exercise. And eccentric movement is really important in tendons, but not in isolation. You're much better off doing both the concentric and the eccentric rather than just being isolated to the eccentric, especially in that strength phase. You want to get strong, so you need both.
Yes. Okay, good. I know we have a lot more to talk, but we've been talking for a while. Anything else that you want to summarize before we wrap up?
Oh, lots of things. I think exactly what we've talked about today. Be sure you're treating a tendon. That's the first thing. And the second thing we see is people underload tendons. As you say, frightened of loading, please, tendons get better when you load them, not when you rest them. So don't be frightened of loading the tendon. That's probably the two key messages, I would say.
Awesome. And if people want to learn more about the topic, do you recommend anything that they can go for to look it up?
There's a lot of research. There's a fabulous book from Barcelona Football Club called Tendon Injuries in Football Players. It's free. You can download it from their website, and it's covers off all the pathology, all the assessment, all the management, all the exercises, everything. It's a wonderful resource. So I would highly recommend people got that. It's in English, unfortunately. I would love them to translate it to Spanish, and they should be able to, seeing their Spanish, but we'll see.
Yeah, awesome. And if people want to learn more about you or contact you, how they can find you?
Not very easily. I tend to be very, very quiet. I don't have a massive social media presence. I'm on Twitter. That'd be about the only thing that I'm on. And I tend to try and keep it fairly low profile if I can.
Okay, so people can find you there. Jill, thank you so much for taking your time to come share all this knowledge, very practical tips and differentiation. Was very helpful, so I appreciate you so much. Thank you.
My pleasure. Thank you so much for asking me.